Foundation, CME, on the nutrition, updates in nutrition for frail elders in the community. Home Nursing Foundation is the largest home healthcare charity in Singapore, providing home medical, home nursing, therapy, and home personal care to more than 5,000 frail and vulnerable patients each year. We also run 2 senior care and community rehab centers at Hougang and Buangkok, as well as an active aging center to serve the needs of both dependent and well seniors in the community, with the aim to improve their overall function, health, and well-being. Under Dr. Ng's leadership, we have started this series of CME and CPE to raise our understanding and practice of holistic medical care, person-centered care to our patients and their caregivers in order to empower all our patients to live joyfully in the community. In this series, we have covered topics such as functional rehab, dementia, falls and osteoporosis, mental health, Parkinson's, and wound management in the community. You are welcome to use the YouTube links to access these videos that we have recorded in the past. This afternoon, we are very happy and eagerly looking forward to the sharing by Dr. Ng himself, as well as Ms. Ling, who has kindly agreed to share their Saturday afternoons to share with us these very important topics. So please welcome them and hand over the time to Dr. Ng.
Thank you, Christina, and welcome, Ling, and all of you in the audience. Very happy that we're here today to share with everybody about our latest collaboration with Tock Hospital on the piloting of the Eatwise program to help our patients who are receiving tube feeding to improve on their nutrition and the overall well-being. And actually, that is the main purpose of this afternoon's webinar. But I know many of you here are also here, not just for the education, but also for the CME points. And I would like to just share a little bit from a doctor's perspective. Actually, when I think about nasogastric tube feeding, it's something close to my heart, and it's something that I understand is not easy to work on, on a day-to-day care for the patients. Many years ago, I had a good fortune to receive some government funding to go to the United States to learn about palliative care for the frail elders. And one of the very important lessons that I learned was how seriously the palliative care physicians there treat and regard the use of enteral feeding. And Professor Tim Quill gave me an article to read, and it's about the decision making around tube feeding. And today I'm going to update it from the source, and then share with everybody this particular set of guidelines. And but with that in mind, we would still like to hear later from our dietitian, how can we improve on the nutrition for our patients who are receiving tube feeding. So I will just be discussing from a doctor's perspective, the indications, the limitations, and conversations around tube feeding for the frail elders. And our webinar originally was meant to target the community aged care physicians, much like our doctors serving in our home medical service in HNF. So the topic was originally targeted for doctors, but now we have broadened the outreach to all the community health and social care workers, and we hope that this is useful for you as well. So we know enteral tube feeding is feeding through the gut. Enteral means the gut. So it's a valuable and important treatment modality, both for acute and chronic illnesses. And we know there are many kinds. We are most familiar with Rouse tube, the nasogastric tube, but we also have tube that go all the way to the duodenum or the jejunum, as well as PG insertion. And there are many other stoma treatment feeding that is also commonly seen in our home care setting, but it's just for us to be aware. So medical indications and contraindications, this is a list I got from a summary article that was quite a while ago, but I think the indication and contraindications still remain largely the same. So under medical, if you have very serious inflammatory bowel disease, Crohn's disease, ulcerative colitis with a lot of malabsorption, you may still need some kind of nutritional supplement. Acute organ failure, stroke is one of the commonest reasons why we put nasogastric tube. Motor neuron disease, brain injury, Parkinson's disease, brain tumor, surgical use, pre-op, post-op. A lot of people use NG tube feeding to maintain the functional airway and to have enteral tube feeding. Then of course, you have severe trauma, especially those on the face. In psychiatric condition, anorexia nervosa, and more commonly used are people who are very seriously ill in ICU, and so on. What are the contraindications? Is when you do not have a functional GI tract, like a IO or ileus. Complications of tube feeding, those of us in the community, we see it quite frequently. So there are a lot of mechanical ones, like unable to pass a tube. So those of us in the community, we must have encountered it many times. Malpositioning, I hope none of us will encounter this, like entering into the cranium, very rare, but it can happen, and the trachea. Unwanted removal is very frequent. If you go to a nursing home, a lot of seniors are tied to the bed because they like to remove their tube. And tube being blocked, sometimes it happens, and in the middle of the night, you receive the call. What I do is I ask them to use fizzy drinks. Not sure whether it is still the right practice or not, but Coca-Cola, 100 plus. But you can also use a bit of Eno to the effervescent can help you dislodge it. Pain is very common. I used to have a nurse with a home care nurse colleague, but in a different agency. She wanted our service to support insertion of nasogastric tube to the father because she cannot insert it herself. She will cry whenever she insert it for her own father. Nasal erosion, sinusitis, otitis media, hoarseness, and so on. All these are also possible. GIT, diarrhea is quite common with enteral feeding that we encounter. I don't see so much of constipation, but more diarrhea. Reflux and aspiration pneumonitis is almost certain because you cannot close the esophageal gastric junction. Metabolic refeeding syndrome for people who are starved for a long time and you suddenly feed them, there'll be a lot of hypophosphatemia, hyponatremia, and hypokalemia, and so on, all due to the metabolic nature of sudden feeding. Then, of course, all the other metabolic complications. Then feed contamination resulting in gastroenteritis. So the main gist of my own section is to discuss with you an article that, as I mentioned, was given to me by a palliative care physician. And apparently, the Monroe County Medical Society update their website, and these guidelines has been updated all the way every 2 years. It's now in the 2022 version. And I checked with the one that I received in 2012. It wasn't very different. There are some update on their instruments, and they're supposed to review again this year. So how do we approach if you want to insert nasogastric tube? First of all, you need to be aware of the signs. So we know many of our patients who receive nasogastric tube, they receive it because of the top conditions that I've listed here, especially those of us in community aged care. We will encounter frailty a lot, advanced dementia a lot. Advanced cancer, maybe those of you who work in hospices, you encounter a lot. Persistent vegetative state, we have seen that too, ALS. Dysphagic stroke is quite common. So, and why do we insert nasogastric tube? There are usually these three purposes. Either we want to prolong life, or we want to improve quality of life, or functional status, or we want to enable some kind of potential cure to the underlying condition. So let's see what's the evidence. The evidence are all cited below. Apparently dysphagic stroke for people with high function and minimal comorbidities, it will prolong life. Okay, so enteral feeding, of course, if you need it for long term, nasogastric tube is very uncomfortable. So a lot of evidence here are based on PG, peg tube feeding. What about dysphagic stroke for people who are very frail, low level of consciousness, multiple comorbidities, poor functional status? Apparently, the evidence is that in a short term, it can still prolong life, maybe they can come out of this low level of consciousness and can be rehabilitated further. So there's a chance that it can prolong life, but unlikely in the long term, especially if the function and comorbidities is very severe. For ALS, it will prolong life. Permanent vegetative state, there are a lot of people on PG for a long time, so this will prolong life. What about advanced frailty, advanced dementia, and so on? Apparently, there's a article, some of the article I went to really study, like the number 5, Tino et al., does feeding tube improve survival? For those, they did a very large group, tens of thousands of people, and compared with the control, it didn't quite improve the likelihood of survival for frailty and advanced dementia. So although I went to research on another article, which is not quoted in this particular guidelines, is from Japan, but the group is smaller and it's not randomized control. It was based on physicians' decisions to insert nasogastric tube. It seems to prolong survival. But of course, the methodology is slightly of a lower grade than the article number 6. So perhaps it is true that the evidence is very strong that for frailty and advanced dementia, it doesn't quite prolong life. Let's talk about quality of life. So far, for those with dysphagic stroke, it does improve quality of life if they had good function beforehand. For the rest, some are uncertain, but the rest are mostly unlikely, especially those in HNF we see are mostly frailty and advanced dementia. It doesn't improve quality of life. And lastly, does it potentially allow a cure to happen? So apparently, you see, all these conditions are unlikely to be curable. So even by nasogastric tube insertion, it doesn't help you to cure a person. Okay, so this particular approach also asks us to weigh the benefits and burden of tube feeding. So what are the benefits? For dysphagic stroke patients in good health, ALS and so on, it may prolong life. Dysphagic stroke in previously poor health may prolong life in the short term. Other benefits, and perhaps this is probably why we do nasogastric tube insertion a lot, is to enable family members and caregivers to maintain a sense of hope and to enable them to avoid feeling guilt. And also the choosing of treatment options is very painful, and and as a community doctor, we need to respect the emotions, feelings, views, and preferences of caregivers as well. And it allows family and caregivers additional time to adjust, especially when death and dying notion is too sudden for them to accept. It is sometimes good to buy some time. Of course, maybe against the wishes of the person who is receiving tube feeding. But sometimes if you haven't had any ACP done before, nobody really knows. Burden. What are burdens of tube feeding? Most of them are unlikely to improve on their quality of life or functional status. And persistent vegetative state patients are not likely to improve quality of life. They'll probably just be surviving, but we can't really hear from them. And there may be patient agitation. We see this a lot. And so patients, a lot of them are restrained as a result. And there's a risk of aspiration is the same or greater than those who are being hand-fed. And stroke patients in previously poor health, with advanced dementia, cancer, and so on, there are a lot of side effects like irritation, leaking, diarrhea, vomiting, nausea. And also one of the articles that I quoted just now, it did not improve. And in fact, one of the longitudinal study on 60 over 1,000 people found that those who receive PEG tube have higher chance of getting pressure ulcers, apparently. Okay, what about alternative? There is this approach called the careful hand feeding. So what is the benefit? Patient is able to enjoy the taste of the food, especially somebody who likes durian, the consistency is very easy to swallow. The patient has great opportunity for social interaction because they have to hand feed. And then the patient's wishes and circumstances can be taken into consideration as pertains to pace, timing, and volume of feed. Like if they say I don't want, they can stop. Because tube feeding, they can have no choice, they have to be fed. But if you hand feed them, they can say I don't want, I want, so you can respect their choices. But the burden is that there's a lot of resources to feed a person slowly. And sometimes the patient and the family worry that they are not doing everything in their power to address the feeding problem. Are we starving the patient? And are the patient and family feeling that they are not in not choosing the option that could prolong life, are they hastening death? So there are all these thoughts and uncertainty that can haunt the caregiver. So these are all very real. So what is the approach? First of all, we need to know, is there an issue of nutrition? So number one, is there weight loss, 10% over 6 months, decreased feeding, more than 25% left uneaten, pressure injuries, and enteral feeding, enteral or parenteral feedings, and apparent aspiration or dysphagia. So if there's anything like that, we need to consider that we may need to do something about nutrition. And the second thing is you have to perform a global assessment and corrective action. So before you insert nasogastric tube, you need to do a proper assessment of the nutritional status and what are the factors that prevent them from feeding. Is it because of sepsis? Is it because the stroke is fresh? They may recover gradually. Should we assess later before we insert nasogastric tube? Or should we insert nasogastric tube but to review the swallowing a few weeks or a few months later when the brain start to recover? So what are the things that impede feeding? We need to assess. And then the other three are related to prognostication. What is the underlying condition that lead to this malnutrition or nutritional challenge? Is it dementia, depression, or other neurological condition? How are they? Are they treatable? And then stage of illness. Is there constipation? Because all these things can actually be a cause for the dysphagia or poor feeding. And hydration. Hydration itself can shorten the life expectancy of a person, but also the hydration status may also impede a person's ability to swallow consciously. So that's number two. Then if you can go through this, and if the patient can improve, if yes, then you can continue treatment until they improve, and then we can review whether we need the nasogastric tube at all. But if the patient cannot improve, then we will need to do a proper discussion. So nasogastric tube, recently Priscilla and I, we were talking about it in a patient's place. They were very worried because she's eating very less. But when I added the true amount that this lady was actually feeding, it was about 600 to 700 ml, which is enough, they'll be mildly dehydrated, but you can still have a proper functioning kidney function. So it was not too bad as you see. So before we reinsert nasogastric tube, you need to assess the understanding of the health status, do an ACP if it not been done, what are the hopes and concerns about future, values, preferences, cultural and spiritual concerns, general goals of care, all viable options, placement, operations, and so on related to nasogastric tube. You have to explain and also consider, is there enough caregiving at home? And what are the benefits and burdens as we shared just now when at the beginning of this approach. Continuing from here, if after we discuss and the decision is still to insert the PEG tube, if the decision is yes, then we need to discuss the components and limited trial. What are the goals? What are we inserting this for? Is it for prolonged life? Or is it because I think that the depression will improve, then I should insert? Or that I think this is still a very fragile phase of the stroke. Maybe after a while, he might regain his dysphagia, revert the dysphagia. So I need to have some kind of goal to establish and to have an aim, and then to trial it. Then after that, we will, in this particular protocol, they have a tube feeding guide that whoever is inserting or discussing with the patient and family, they need to go through. So I will go through in the next 2 slides. And then we will reevaluate swallowing ability after the period of time, and then if necessary, we go up again to the discussion tree. If the decision is not for PEG tube, discuss of expected cause of illness and functionality, go through the guide, and then careful attention to comfort care, hospice referral, and so on, and offer assist feeding if necessary, careful hand feeding, but we do not force the food if the patient refuses. Okay. Patient resident preference should determine the type and amount of food. Excellent mouth care is very important. So recently I have an exchange with a friend of mine who is a specialist in he's a multi-talented specialist in emergency medicine and internal medicine, but he's now studying lifestyle medicine and all his science about it. He says that when a person is sick, automatically the body will not want to feed, and and this will allow the healing to take place. So sometimes it's good to let the patient be the guide on this. So this is something interesting for us to consider. When a person is really severe dementia, multiple stroke, and the body is like really in an inflammatory response, their lowering of appetite could actually be helpful for their well-being. Okay, so this is the form that this Monroe County Medical Society guide is using. So this is actually the northern part of New York State, so they use this. So if you want to insert nasogastric tube, you need to go through this in order to be more mindful and purposeful of the use of nasogastric tube. Have I completed a global assessment? No reversible factors or reverse factors has been identified and addressed, but eating, feeding have not shown significant improvement. So what is your assessment for this? Then for this patient, the assessment of potential benefits and tube feeding are as follows. Okay, to prolong life, what kind of condition? Is it likely, unlikely, or uncertain? To improve quality of life, is it likely, uncertain, or not likely? Or to enable potentially curative treatment, is it likely, uncertain, or not likely? So for those conditions that I shared just now at the first slide, many of them are not likely, but there are other conditions that like severe depression, anorexia nervosa, maybe early stages of stroke, that can be likely of improvement. So we will need to assess accordingly. And then we need to discuss, discussion has taken place with who are the people, patient, the donee, the public health surrogate, health agent, and so on, or the family members, family conference. And what did we discuss about? Understanding the condition, benefits, burdens, advanced directives. And then the above have been documented, and tube feeding will be started or not started. So that's the valid decision. If we decide to start, you'll need to be very clear what is the purpose. Is it to prolong life? Is it to improve quality of life, or whatever others? So maybe it's to prolong life, and others is for the family to come to terms. I feel this is quite common. It's the reason why we insert nasogastric tube. Because the benefits or failures of tube feeding are likely to occur, we need to reassess whether is it still indicated, or we just put nasogastric tube and every 1 month or 2 months we will have a change. Nobody review it. And then subsequent assessment will be based on these are the things that we will be doing. So these guidelines help the practitioners, the nurse practitioners or the doctors to be very aware of the purpose why we are inserting nasogastric tube. Okay, so I'm finishing my section. So in summary, prior to making a decision about nasogastric tube insertion or PEG tube insertion, we need to conduct a comprehensive assessment looking for reversible causes of inadequate nutrition. And we need to review the medical evidence as it relates to tube feeding and PEG tube. We need to discuss the evidence with the patient or the healthcare agent or the family member. And then we need to let them be aware of the current present medical condition, discuss the benefits and burdens of tube feeding and whether this will be consistent with the patient's wishes. However, we know that sometimes we will still make the decision of nasogastric tube if this is elected, we need to develop specific goals and time intervals for reviewing whether these goals have been achieved. Okay, so I shall stop here. If you have any questions, you can type onto the Q&A column. We would like to hear from Ms. Ling on the Eatwise programs and guidelines. Part of it is to educate community doctors like us. How do we assess and improve the nutrition of our patients? Ling, thank you.
Okay. Let me. Can everyone hear me? Okay, thank you. Yes. Thanks, Dr. Ng, and thanks for having me here today. So yeah, my name is Pei Ling. I'm currently practicing at Tan Tock Seng Hospital, and just that this Eatwise SG things, it's something going to happen nationwide from next year onwards. And I'm just going to take the opportunity to carry on the story from Dr. Ng as well to talk about if there's a true indications for tube feeding, then how can we safely start the enteral feeding. Okay. So I'm just going to share on, when we start on the tube feeding, then what are the types and selections of the enteral nutrition formula that we should be selecting. And before we start on feeding, right, then how can we identify if there's any risk of refeeding, and then how can we then start carefully to prevent the risk of refeeding to happen. Then maybe we can talk a little bit about, calculating the requirements of the patients. So to help us to determine what will be the target that these patients or these residents will need. And then perhaps we can also talk a little bit about, troubleshooting for tube feeding, because I think earlier on, Dr. Ng also mentioned some of the common complications that you will usually see on tube feeding, like diarrhea, or even, high NG aspirate. So in terms of nutrition-wise, or maybe, the formula selection-wise, maybe there's something that we can do to help to troubleshoot. And I guess in the community, we also will see people starting on traditional feedings. So those who are really using the tube feeding just for the interim, and then when they start transitional feedings, then how can we actually safely start them to transit to oral feeding? Then I will just take a little bit of time to introduce the Eatwise SG and some of the collaboration that we are working on with HNF, and then we'll go on to Q&A. Okay. Yeah. So just wanted to have a quick share on the type of selection of enteral nutrition feeding, whereby most of the enteral nutrition formulas that we are choosing, right, it's actually complete in nutrition that will provide all the macronutrients, that's the calories, protein, and fats, as well as the micronutrients that the patient required when we are given at the adequate amounts of volume. And hence, it's actually becoming suitable as a sole source of nutrition. The enteral formulas, right, usually can be available in liquid or powdered form, where for the powdered form, we can always also, dilute in various dilution factors to make sure that we still meet the requirements while maybe keeping to certain fluid requirements. And almost all of the enteral formulas are lactose-free and gluten-free. So I think sometimes some of the families or some of the patients might be a bit concerned if I'm going to start on, these milk feeds, right? Because it's still called as milk. Then they are concerned about, oh, I drink milk, then it will causes me diarrhea. But that would be not so much of the concerns when it comes to these enteral formulas, because generally they are lactose free, and hence they are actually suitable for everyone. Okay. And for the formulas, usually we will categorize them into either we call it as a standard formula or a disease-specific formula. Or there's also a modular formulas like myotin, beniprotein, that usually only gives us one type of the nutrients that need as a top-up wise. So standard formulas, that's something that everyone can use without any concern about diseases, while the disease-specific one is designed for a patient with various disease. Okay. Yeah. So for standard formulas, I think these are the common one available in Singapore. So we have the powdered formula like Ensure Life powder, Boost Optimum powder, and the Cow Presswin powder. And then we'll also have the liquid formula, like Ensure Liquid, Ensure Life Liquid in the bottled one, or the Boost Isocal Gravity. In a hospital, usually we prefer to use a liquid formula so that it's lesser needs for preparations, and in hospital, usually we also say like, oh, lesser risk of contaminations because of powder. You need to take it out, dissolve water, and then make sure it's dissolved, and then you put out the tube. But in community, powdered formula might be something a bit more preferred because in terms of cost-wise, powdered formula usually a bit cheaper. And I think sometimes some family may go over to say JB, Malaysia to buy the powdered formula. That's even much cheaper. So regardless, let's say whether we choose, let's say the liquid formula or powdered formula, or if actually, let's say the patient is started on liquid formula, but when goes home, they wanted to change to powdered formula, it's always interchangeable. And there's always, I say, we can refer to these dilution factors to help us to know how much we need to prepare. Generally, if it's referring to 1 can of the Ensure or 1 bottle of the Boost Optimum Boost Isocal, it's equivalent to the standard dilution for each of the powdered formula. So as long as actually, I say, family is actually diluting according to the recommendations on the packaging, then it's actually pretty much equivalent to 1 can already. So then if actually at home needing that switch, that will be something that can just let them know how to do it. Then we also have the disease-specific formulas. First one is actually, of course, the diabetes formula. Diabetes formula so also have the powdered one or the liquid one. And there's also a bit more concentrated formula like a Diben or Glucosinate Advanced. So Singapore don't have, like, say, too much of the choices. I think a good thing and bad things. Good thing is actually you don't have to scratch your head to tell the family which type or which brand to buy. But of course, the downsides, they have a limited choices. Like if they so-called, like say, don't like the taste of it or find it a bit expensive, they want to have other brands. Yeah, so pros and cons on that. But generally, right, the diabetes formula, they all contains fiber in there. That's actually, like say, something to help with the sugar level control as well. And they're also lower in carbohydrates as well as actually the lower in glycemic index. That also helps with the sugar level control. Yeah. Then similarly, let's say we can always dilute accordingly. If we need to switch from a liquid formula to a powdered formula, so using these standard dilution factors, also similarly, like say, prepare according to the packaging recommended amount. Then this comes to, like say, there's also a renal specific formulas. Renal specific formulas, there is this high protein formulas, and there's also the low protein formulas. In general, the low protein formulas will be the one that we use for patients like pre-dialysis stage. So CKD, say 3, 4, 5, not starting a dialysis yet. So we choose the low protein formula, so restricting their protein intake. While the high protein formula would be the one that usually we use for patients who started on dialysis, because actually it's actually higher protein. The Nepro would be something that a bit tricky because you can see it's actually a similar name and similar so-called bottle. So they have to make sure, like say, the patient or family, if need to use a renal formula, make sure they choose correctly either the HP, which is high protein, or low P, the low protein formulas. Ideally, is if the patients required renal formulas, will be good if can refer to dietitians, or maybe, let's say, have a discussion with dietitians or consult dietitians, so that to make sure, oh, we are actually using the correct formula for the patients. And also because they are higher in calories, so that sometimes we thought yeah, we still need to give, like say, if the usual one, say 6 bottles or 5 bottles per day, actually the calories might be over because it's ×2 the concentration. Then for patients who are requiring fluid restrictions, or they are really having a very poor oral intake, this is actually when we use for, like say, the high protein, high energy formulas. So for tube feeding, That's whereby, like say, if the residents requiring fluid restrictions, or if they are having issues with aspirations, then these are the formulas that we will actually looking for, so that lesser volume can be given. So there are actually quite various types that we can choose. Okay. Then juice-based formula, we have the resource fruit or the Frasabine juicy. They are not the complete, they don't have the complete nutrition, and they are lower in vitamins and minerals. Hence, usually these will be something that we only use for patient as a little bit of choice, or if they need to be on the fat-free diet, let's say colic issues, but then they still need to be on the tube feeding, then this will be the one that we will use to give, let's say, the nutrition. And usually it should be used for short term only. And as it's actually named as a juice, fruit juice, it means also, let's say, the sugar level is actually higher. Hence, it's actually not suitable for a patient with diabetes. Okay. So usually for tube feeding, we hardly will actually use a juice-based supplement because it's not complete nutrition unless really colic patients who needs to be on a fat-free diet. Otherwise, it will only be somehow, like say, some patient who wanted to have a little bit of, like say, taste preference kind, smell preference. So they want it a little bit like juicy kind of like smell, even though it's actually tube feeding, they can't really taste it, but just for the smell. And hence, there could be a potential compromising with maybe, like say, one bottle or a little bit of, like say, the fruit based supplements to alternate with the milk based supplement. Okay, then there are also, like say, the very specific formulas that we use on top of just the ordinary, like say, the milk-based supplement, the standard formula, to help with certain purposes. So this would be, like say, one of it is actually the wound healing, A-bound arginine or glutamine plus. They are the special formulas that usually added to the canned milk, or actually, like say, added on to the usual formulas to help with wound healing. So the arginate or actually the glutamine are the one that we're looking for to help the wound. Ideally, it's actually used for patients with wound stage 3 and above, and it has to be, like say, consistent. So after, like say, starting on it, it's not like say, oh, I start one day, then I can stop. But actually the recommendation is ideally to start for at least 2 weeks, then to monitor, to review again to see whether wanted to continue or really wanted to stop. So if there's a wound patient and they're on the tube feeding and wanted to consider using like A-bound or arginate to help with the wound, then can refer to dietitians or discuss dietitian also how we can proceed about. There are also, like say, the specific formulas such as for the one for oncology, like say, cancer treatment one, which contains the EPA, the EPA and DHA. Sorry, I think typo here. Okay, so like the brochure, powder or liquid and supportant, and then there's also this special, like say, juicy taste one, but they are not nutritionally complete, which can be given on top, like say, just the usual standard formula. And there's also the semi-elemental one, meaning they are partially digested, and hence it will help with the absorptions for people with maybe like malabsorption issues or short gut issue or even a colic. So this will be used for people who have like gastro issues or done through, like say, the GI surgery, and their absorption is somehow a little bit, like say, affected, and hence they need this semi-elemental formula. There are also, like say, immunonutritions, where this is usually used for patients when they are preparing pre-op or post-op for 5 to 7 days to enhance the recovery or preparation for surgery. They are complete nutrition. So this one, I think those who needs to start on, like say, or plan for surgery one, usually the GS doctor might like to add on this oral impact to help with the recovery. Then we also have, like say, the modular formulas. This is the one that protein powder to add on to the formulas to aid or actually optimize the protein intake. Okay. So before we start the patient on the tube feeding, exactly, first thing is we will need to identify if there's any risk of refeeding. Because I think one of the indication that usually we'll see in Singapore when to start the tube feeding, it's when they have like dementia, very poor oral intake for quite long, really can't really swallow already. Then, okay, family decided they still wanted tube feeding. And they are also the group with potential high risk of refeeding. So for refeeding risk, unfortunately, it's really based on certain criteria to help us to identify if this person is at high risk of refeeding. Before we introduce the nutrition, their electrolytes might be normal, like just a basic. But once we reintroduce the nutrition, especially carbohydrate like the sugar, it may actually causes the potassium, phosphate, magnesium to drop. And that's actually, like say, some of the refeeding syndromes might be observed like tachycardia, tachypnea, or edema. So to prevent these are the criteria that we use as a reference to help us identify if this person is at risk of refeeding or not. So if the BMI is very low, or they have a very significant unintentional weight loss within the last 3 to 6 months, or you know that there is really a very little or almost no nutritional intake for more than 10 days, or if like say poor oral intake and then the blood test done, right, already show low level of potassium, phosphate, or magnesium, this will be the one that has high risk of refeeding and we need to be careful. Or otherwise, if they meet any of the two following criteria, such as a low BMI and then still have unintentional weight loss, and then if they don't have, like say, much nutritional intake for more than 5 days, and if they also have, like say, alcohol abuse or drug abuse, these are the ones that actually will also have risk of refeeding. So if after we identify patients who are at risk of refeeding, generally we will, in the hospital, we'll ask the doctor to start thiamine. And then in the community, we will actually, like say, hope that the doctors can actually help with starting the thiamine, at least 100 mg. If we can start with, like say, 200 mg, that would be great as well, using the PCB pot. I think that's the common one. And if we are also able to introduce like multivitamins, they can either dissolve in the water or the effervescence type, they can feed down the tube and to feed the patients for 5 to 7 days consecutively. This will actually help to minimize the refeeding risk. Ideally is to check the serum potassium, phosphate, and magnesium before and after starting the tube feeding. And then, of course, after identifying the risk of refeeding, and if there's a risk of refeeding, we start the thiamine multivitamins. Then we can estimate the daily requirements of the patients to help us to know, like say, how much we need to start and how much are we aiming to target for. So how to calculate the requirements? These are quick methods that actually everyone can use in the community as well. So just to have a quick one, we can actually make use of this quick calculation method, which is 25 to 35 kcal per kilo body weight per day. That will tell us, like say, the estimated total energy requirements of the patients already. If, like say, you wanted to play safe, you can use, like say, the lower end one as a start, then monitor, then look at the weight. If you like say, no weight gain, you want the weight gain, then yes, we can actually increase accordingly. Similarly, for protein, can make use of 1 to 1.5 grams protein per kilo body weight per day as the needs. And then also fluids, using 25 to 35 mils fluids per kilo body weight. So this will actually generally tell us, okay, so how much calories, how much protein, and then what are the fluids target that we wanted to aim for already. So for patients with no risk of refeeding, tube feeding usually will still start at, like say, no more than 50% of the estimated target energy and protein as a starting level. Then we can actually grade up accordingly. And I think based on the latest the clinical guide for tube feeding, it is suggested that each feeding volume including the water, should not be more than 400 mils. So like say we need to calculate the milk feeds plus the water. Total, we still need to keep within the 400 mils. So then, say, usually monitoring the renal panel will be something that still good to monitor lah, to see how is it, and of course, continue to monitor the tolerance. Okay, so then after we calculate, right, then a simple way to help us to determine what would be the appropriate enteral nutrition formula is, so first we can look at, let's say, if the patient will need any fluid restriction or need to limit the fluid volume, let's say, for example, for high aspirates or actually for secretion management, or if the patient has any renal failure. So if yes, it'll be good to refer to dietitians. And as a start, right, you can still, like say, start even using a standard formula, like say Ensure or Glucina. But before grading up, it is good to actually seek the input from a dietitian to know that, okay, so are we supposed to change to another more suitable formulas or not? If don't have any fluid issues or renal issues, then the next question we can ask will be, is there any, like say, diabetes? Is the person diabetic? If yes, yeah, so we can just proceed to choose either glucina or nutrient diabetes. Or if, like say, no diabetes, then that's the standard formula that we'll choose, either the Ensure or Boost Isocal. I mean, liquid will be something easier to use because you can just tell them, like say, to put in how many mils each time. That'll be easy lah. For powder wise, then always need to work on, like say, the dilution factors lah. So that's actually a bit complicated as a starting volume. Usually it might be easier to start with liquid. Then after that, if family is still keen to use a powder formula because of the cost concern, then after hitting the target target regime, then switch to powder formula, it might be a bit easier. Okay, so I guess I say this is actually just a sample calculation on how we can work out, like say, the feeding regime. Okay, so first step, like, we will calculate the daily nutrition requirement. Let's say if the residence is 50 kilos, and then we just use the 25 kcal, I mean the lower end, to calculate the requirements. Then 50 times 25. Okay, so then we know that these residents will need about 1,002 kcal per day. And then we'll then try to see which enteral formula to choose, either the standard or disease-specific formula. So this we're looking at, like say, the past medical history, either got diabetes or actually it's fine. Okay. Then we can calculate the volume of formula needed. Okay. Continuous feeding, I guess, not so common in community. And usually, like say, if started with continuous feeding, we will try to keep 16 hours per day of feeding only in the community, so that it allows the caregiver to have, like say, a bit more, I mean, sometimes to rest, as well as actually, like say, in between to do something. Then if for bolus feeding, yeah, so we'll need to determine the number of bolus feeds per day that needs lah. Usually 5 to 6 will be the common one, whereby, like say, 5 is something that a bit more preferred if possible, because that will help us, I mean, also like give the caregiver a bit more time, a bit more free time for themselves. And also allow, like say, maybe patient wanted to go somewhere, then if 3 hourly feeding 6 times a day, it might be a little bit restrictive compared to, like say, 5 times, so that they have, like say, in between free time that can go out. Okay, so examples that we can calculate, right? So let's say, yeah, this Madam A weigh 50 kilos, then we calculate, like say, the requirements using 25 kcal and then the 1 gram protein. And then if we know this person has background of diabetes. So using the calculation, we know this Madam A will need 1,002 kcal and 50 gram protein. And then the fluids, we use 30 mils, then it gives us 1,005. Because of diabetes, then we need to use, like say, the DM formula, which is like glucina. So glucina is a standard formula. Standard formula generally is 1 kcal per mil. That means if we calculated the requirements, it's 1,002, like 1,1250, then the amount we need from the standard formula, the standard like 1 kcal one, will be just exactly the same volume, which is 1250 mils. And if we can keep to, like, say, 5 times per day, 5 times feeding. So this is how then we can actually, like, say, work out the plan already for the feeding. So these calories will require this amount of the glucina, and 1 can of glucina is 250 mils lah. Hence, we will be able to divide to 5 times feeding a day, which equals to 5 cans of glucina per day. And to make up to the fluids needed, right? Then we'll just need to make sure that water flushes will be around 50 mils times 5. Then this will be, like, say, the target regime that we can give that will also meet the requirements already. Okay. So some, like, say, ways that help us to, like, say, how we can grade up, right? If we wanted to go a bit, like, say, slow, conservative, then usually can be, like, say, start 1 can a day, then you grade up, can be grading up, like, say, to 2 cans or 3 cans at the subsequent days, and grading up to the target over the next 5 to 7 days. Okay. So I guess I say starting with tube feeding already, troubleshooting will be something that we usually will actually, like, say, try to see if needed or if the patient has any tolerance issues. And the potential issues with enteral feedings that commonly we'll see, I think just now Dr. Ng also said, like, constipation may not be so common, but the diarrhea will be something common. So we'll actually talk through also. Okay. But in the case if there's actually constipation issues, then of course laxative will be something that gives. But then in terms of, like, say, the nutrition or the formula wise, this is something that we can consider, that switching to a fiber containing formula. So for example, like, say, Javeti or Glucina, those type of, like, DM formula will contain fiber. That will maybe helps to give some fiber to help the stools. Okay. Then the other thing that maybe wanted to, like, say, monitor will be the hydration, making sure that there's adequate water given to the patients. Okay. And okay, so if in the case there's actually some nausea, vomiting that happened, sometimes, right, what we can actually look at is the feeding rate. So sometimes when they feed a bit too fast to the patient, that's actually something that causes the patient to have nausea or vomiting. The volume, sometimes the volume is actually too large, right? The patient not feel comfortable. That's the one that actually also may cause them to feel nausea or vomiting. In that case, right, considering a more concentrated formula will be something that can help with the conditions. Of course, nausea and vomiting, it could also caused by potential delayed gastric emptying. That's also potentially related to the glycemic control of diabetes, and monitoring the sugar level at home. If actually, like, say, telling us that the blood sugar level is not so controlled, then maybe this will be something that we want to target to help with it. Otherwise, if it's a true, like, say, always having the nausea and vomiting issues, then in terms of the feeding troubleshooting, we can increase the feed interval. So instead of, like, say, 3 hourly, maybe 3.5 hourly or 4 hourly, maybe something can help. Otherwise, considering, like, say, smaller bolus feeding, by switching to a more concentrated formula, maybe would help. Okay. Then for diarrhea, you can see the bar is actually quite but the table is, like, say, quite extensive, because there are various potential causes that can due to. One of it, of course, the common one could be infection. Then if in infections, we would actually, like, say, encourage to consider probiotics to help to normalize the gut flora. So something like lactofort may help, or even things like ProGut or Vivomix would actually help. If it's actually antibiotics related, this will be something that, because we can't stop the antibiotics just because patient got diarrhea. So to help with it, that's whereby we may actually consider fiber containing formulas to help with it. And also can consider adding probiotics to the feed as well. Sometimes at home, because let's say for example, the volume using the bottled one, the liquid one, we may not actually pour all the whole bottle or whole can at one go. Hence, right, the remaining volume, we usually will ask the caregiver to keep in the fridge so that actually next time can still use instead of throw away. So if they actually take it out straight from the fridge and they didn't warm, usually it's not an issue, just like how we actually drink a cold water. But for some people with a bit more sensitive gut, so this may actually causes them to have a diarrhea. And hence, if this is actually the potential cause for the diarrhea, then can advise the family to still try to water bath to warm it down to at least the room temperature before they feed. Okay. Fiber will be something that actually can help also. So switch to a fiber containing formula if they're having diarrhea would actually helps. Okay. Some medication actually does contains laxative in there, especially like say it could contains a little bit of alcohol, sugars in there, which is actually just a natural sweetener kind, but it has the laxative effects. So reviewing the medication, if able to identify those medication, and if able to like say get the pharmacy to help to see potential to switch to other medication, that would be good lah. Okay. The other thing will be potential issues of hyperosmolar formula. So meaning if the feeding regime, if you are using the very concentrated formula, it can actually potentially leads to diarrhea. So some patients who actually drink a bit more, like say very sweet things or very thick kind of things, right? They can actually have diarrhea. And in this case, we will then need to switch them to less concentrated formula already. Okay. And okay. Then there are also issues with like say high aspirations lah. And I think this is also something that quite common in the community, and even we see in the community like home visits. So high NG aspirates, of course, it can be due to like say some of the illnesses, such as like say the GI tract issues. For this one, some troubleshooting that we will try will be considering like smaller bolus, meaning using a bit more concentrated formula. So small, like a bit more like say small frequent meals kind to help with it. If it's actually like sugar level control one, then that's the one that we wanted to target. And if it's because of constipation, then of course treating the constipation will help lah. Okay. There's also issues like say secretion, and I think this is something that always a bit like say in the not easy to manage, yet it's actually a very common issues with tube feeding, especially the tube feeding indication is related to swallowing impairment, such as like stroke patients, long-term stroke patients, or dementia patients where they forgot how they would swallow already. Then the longer they are on tube feeding, right, actually the secretion issues will actually increase. So secretion will be something that as long as we feed something like food down the gut, there is always secretions already. Whether it's actually saliva secretions or your gastric juice secretions. So this is something that we are not able to avoid. I think sometimes the family would always like say hoping that something that can be done to help with the secretions. Unfortunately, it's actually a bit limited things we can do with the feeding unless we really don't feed. So I think this is something that also aligning with what Dr. Ng would mention. Right? We need to understand like what would be the indications that we want to start with the tube feeding. Because if we're talking about quality of life, prolonging life, for certain situations it may not be. Yet when on tube feeding for long, these issues may actually occurs, and they will need secretions, which is a suctioning. And the suctioning is actually definitely something not comfortable. So trial and error, like say when there's really a secretion issues and we still wanted to perhaps like say keep the person a bit more comfortable, it's only a trial and error ways that we can do. So some troubleshooting we tried before, it's let's say for example cutting down the volume of feeds, it may help, or cutting down the frequency of feeding, it may help. But of course, this may potentially compromise the nutritional provisions lah. And hence, more like say, somehow may so-called starve the patients a little bit to help it. And that's whereby the balance will need to be there. Okay. And for all these, like say, issues with enteral feedings, right? If you tried all the strategies, if still no improvement, then I think that's the time where you go to refer to dietitians. Okay. So tube feeding, there's also a group of patients whereby they may potentially like transit from a tube feeding to oral. So the transitional feeding, the indications whereby we will still not pulling out the tube straight away, it's we want to slowly transit the patients from the tube feeding to oral. And because during these processes, right, we wanted to make sure that there's still adequate feeding to meet their nutritional requirements, and also getting them to gradually return back to normal eating habits. Because when they started to swallow food, sometimes they do need a little bit of time for their, say, swallowing mechanism or swallowing, like say, the muscles to so-called return back to the normal state. They might not be actually, like say, some patients may actually need a bit of time to gradually, like say, get used to that swallowing mechanism again. And hence, having the tube still be there so that we don't stress them to, like say, get them to, oh, you must eat this much to meet your requirements, right? By having the tube. So while pacing them to slowly transit back to oral, there's always a tube for them to give the top up of the nutrition through the tube while they actually transit through. And so this is actually like helping in terms of quality of life, more like say helping them to take away the stress while reducing the reliance on tube feeding. So ideally, it's actually we don't want to discontinue the feeding tube until the oral feeding is well established and well tolerated. And this is whereby I say you can refer to a dietitian to so-called, I say, work with the family to help them to transit to oral intake. Usually, when do we consider to wean off the tube is when the patient is able to take in more than 75% of their nutritional requirements orally for 2 to 3 days consecutively. And also, if they are able to take in, like say, a fluid intake of around, like say, 700 or like say 800 meals per day. So actually, that we know that, oh, basically still adequate to help the body functions, then that's a time whereby we can remove the tube already. So of course, I say after we go through all this, monitoring and follow-up will still be necessary. So similarly, like say we wouldn't just start something and then, okay, so that's it. So we still need to monitor the progress, and then if we have any, like say, outcomes they wanted to measure or evaluate, that's the like follow-up purpose. And then of course we want to evaluate the effectiveness of nutrition interventions. Like I mentioned, like say if the tube feeding is just for a short period of time, then monitoring would help us to reevaluate the goals and the targets again to see when are we going to take off the tube, or when would be suitable to take off the tube. Okay, so I guess I say for nutrition part, the parameters that we usually will wanted to monitor would be, like say, the weight. First is actually the weight. It can be done through the physical appearance to see if they are actually, like say, quite muscle wasted, or actually, like say, the body fat's very wasted, or they are actually getting better in terms of physical ways. And the one that usually a bit more easy to look up will be here, like say the temples here or the clavicles. So if it actually looks better, that means we are actually slowly achieving the goals. And maybe that's time we can review our plan. Okay. Then of course the other one could be the injury. If actually improving, that's actually something that we can know that maybe we can slowly tail down some of actually our needs. Let's say started ABOW, then maybe we can slowly take it off from the feeds already. Okay, then this is just to highlight whereby if there's a need to escalate to dietitians so, or when is there a need to escalate to dietitians. So if there is a newly diagnosed medical conditions such as CKD stage 3 to 5, because this may warrant a change in the supplements that we use. Maybe need to change from a standard formula to a renal formula. Okay. Or if there's a newly imposed fluid restriction, so let's say that's whereby we need to maybe choose a bit more concentrated formula, but how much do we need already? And then if there's actually like elevated metabolic requirements or weight changes, so that requires a recalculation of feeds, then yeah, that's a time you can engage the dietitians. And poor tolerance, we can go through the troubleshooting, but it doesn't work. That's where it's time to talk to dietitians again. Then if the patient started on traditional feeding, good to discuss with the dietitians on how to help the patients or resident to slowly transit to oral intake. And then wound will be something that we really encourage, can talk to dietitians so that we can help to plan or manage together with the wound. Hopefully we are able to improve or actually shorten the time for recovery for it. Okay, so that's basically the part whereby I wanted to share on like safe tube feeding. And before we go into like say the Q&A part, perhaps just allow me a little time to share this Eatwise SG framework that it will be rolled out nationwide next year. So Eatwise SG is an initiative to support the population through accessible, affordable, seamless, and integrated nutrition care in the community. Meaning we're trying to build up the capacity and the capability of nutritional care in the community. So to do this, right, actually we also train up our tier 2 providers, which is actually the nurses, and also our tier 1, that's actually our maybe like community partners, for example, AAC, to have some knowledge in identifying the nutritional needs, or actually like say having some basic knowledge to be able to provide some basic nutrition intervention in the community. So there are actually framework that was done up to help to identify when we can actually engage which providers. So there is actually tier 1, tier 2, tier 3, tier 4 that was identified in terms of provider, meaning the tier 4 will be those like say hospital dietitians, like hospital care. Tier 3 will be the one in the community. So dietitian in the community will be called as tier 3. Tier 2 will be those, let's say, non-dietitians healthcare providers, so such as the nurses or even the doctors will be able to help to manage the nutrition interventions. And then tier 1 will be a bit more towards the lay extenders, so like AAC staff or so. So with the framework, there is actually, I say, the criteria made up to help us identify, so in which situations we could have actually engaged or refer to tier 3 like dietitians, and in which situations whereby maybe the dietitians will actually de-escalate the case for the nurses to take over in terms of the care. So with this, actually, we are able to close the gaps in terms of when we need the nutrition interventions. We are able to have that support in the community. Likewise, actually, there's also, like say, for the nutrition support, including like tube feeding cases, like when are we going to escalate or de-escalate the care. So the pilot, there are actually this pilot going on nationwide, I would say, at each cluster. Because it's a pilot, so it's just actually a small, a few stakeholders were actually involved. And actually HNF is actually one of the partners that we are working with, looking at, like say, the escalation part, whereby the nurses will be able to identify if there's actually any cases will need the dietitian support, and then they'll actually escalate to us. Okay. So I think, like say, HNF doctors, you are actually welcome or encouraged that you can actually, if you identify any dietitian, any patients who need dietitians support, then can actually get to us yeah, during the pilot. Whereas I think other partners, maybe next year will slowly roll out, like say, the workflow and the collaborations. Okay, so that is actually, like say, just a quick one I wanted to share about this Eatwise SG, and hopefully, once it's actually rolled out, we're able to have a better support in terms of nutrition in the community for everyone. Okay, I think that's all that I wanted to share today, and thank you everyone. And I think now should be the Q&A session.
Q&A. Yeah. It's already 3:10, but we do have 3 questions that's been posted, and I think they're all very good and interesting. So there's first question is about the use of whey protein, those that gymnasts used to use. So are they equivalent to Propass and Maltin? What do you think? Can the family use it instead of Propass?
Okay. So for this one, right, actually the family can still use it in replacement to Martin or the Propass or Benny protein. But I think the other thing maybe we'll need to need a bit of consideration will be because Martin and Propass or Benny protein, they are a complete group of the protein, the amino acids, whereby some of the protein powder that used for gym, it could be very high in certain type of protein only, say like leucine. And then if as just a quick a bit of top up in terms of protein, like while the patients still able to get the protein from other sources, so this one as a top up, I think it's fine. The other thing maybe need to consider will be the volume, because generally the scoops, the amount for those gym-based protein is actually very large volume compared to the one they want to use for Martin or Propass.
Oh, okay.
So that one adding in could be quite a volume.
Thank you.
It's still okay to use.
Okay. The second question is related to your calculation. The weight times 25 is the basal metabolic requirement. Which weight do we use? The pre-morbid weight, whether they because now perhaps they are overweight or they are underweight. Do you still use that, or do you use an ideal weight times 25?
Okay. So for us, for dietitians, we usually use the actual body weight to calculate. And then if for patients who are underweight, then we'll just plus 300 kcal as a so-called a weight gain factor. So that at least we can know that this is something that we're projecting in terms of like gaining the weight and how much are we projecting the weight gain to be. And then for overweight, then we will actually minus 300 kcal. So similarly, we know actually we are deficit by how much and then what we're expecting. Yeah, I think this is something that also can be done.
Okay, thank you. The last questions for today is questions about secretions management. Are there any differences by reducing the milk feeds or changing the type of milk feeds to improve on secretions?
This one in terms of secretions, right? It's a bit trial and error, to be honest. Unfortunately, it is trial and error. But generally, like say, because the overall idea is like say trying to reduce the volume or amount of the food. So sometimes what we can do will be like say we really use a concentrated formula, and then from there also if we are able to reduce the frequency of the feeds, then that will be something that we like say will target, will try to do.
Okay, thank you very much, Pei Ling. I really find your lecture very systematic, very structured, and all the important informations are there. It's very practical and very helpful. Thanks so much for your time. And and thanks for having HNF as your pilot partner for Eatwise SG. Okay.
Yeah, thank you for having. Sorry.
With that, we'll close the session. Christina, would you like to close the session today?
Yes, thank you so much, Pei Ling. And I would also take this chance to invite all our colleagues to our inaugural Age Well Symposium on the 11th of October. Registration is free. There's a face-to-face symposium at the HDB Hub Auditorium, very central. And this is followed by a championship where our seniors will come together and compete in exciting intergenerational games and events. So please mark your date and come for our Age Well Symposium and Championship on the 11th of October. It's a Friday. I hope to see you there.
Yeah, thanks, Christina. We have got Minister Janil Puthucheary to grace the occasion. And the symposium, the scientific content is actually very rich and interesting. We've got Professor Angelique Chan sharing about her research on social isolation and loneliness, and Yai from Montfort Care and Charmaine Tan from AIC sharing with us about the designing of AAC, Active Aging Centers for Singapore. And we have Angela Young from PCF to share about their intergenerational program. So we look forward to see all of you in this age-old symposium. Very integrated approach to community care for the seniors. Okay, so thanks a lot for your time.
Take care,
Goodbye.
everyone. Have a great weekend. Thanks,
Bye-bye.
Pei Ling. Bye-bye. Thanks, Chong.
Thanks,
See
Philly.
you.
Bye-bye.